Welcome to Learning Thursdays. I'm Dean Hale with the OASAS Learning and Development Unit and your host for today's presentation. Today's presentation is titled Similarities Between Psychiatric Symptoms and the Effects of Substances. And joining me today is Dr. Grace Hennessy, Chief of Addiction Psychiatry for New York State OASAS. First, a word about Learning Thursdays. Learning Thursdays are offered to behavioral health professionals as a free learning opportunity with the goal of improving the knowledge and skills of the New York State substance use disorder workforce as we strive to improve the lives of individuals needing prevention, treatment, recovery, and harm reduction services. A goal of Learning Thursdays is to support the professional development of the treatment, prevention, recovery, and harm reduction workforce. We do this by offering regular presentations that are relevant to today's substance use disorder treatment professional. As always, if there are any questions, comments, or suggestions, please feel free to contact us at the Learning Thursdays mailbox. You can use the same mailbox to express an interest in providing a future Learning Thursdays program. And now it's time to start the presentation and welcome Dr. Hennessy.
Thank you very much, Dean. So since it's common for individuals with substance use disorders to have psychiatric disorders and vice versa, it can be difficult to determine if symptoms you're seeing in individuals you work with are due to a psychiatric disorder or due to using alcohol or cocaine or other substances. So for this Learning Thursday, we're going to talk about the similarities that exist between symptoms of psychiatric disorders and the effects of substances. So before we get more into that topic, I wanted to briefly review the definition of and some data about co-occurring disorders. So co-occurring disorders has a pretty simple definition. It's defined as the presence of at least one substance use disorder and one psychiatric disorder. Other terms have been used to describe individuals with co-occurring disorders, such as duly diagnosed, duly disordered, mentally ill substance abusers, and substance abusing mentally ill. But these terms are either outdated or incorrect because many individuals have more than two disorders. And the last two, mentally ill substance abusers and substance abusing mentally ill, just kind of have negative connotations. So we don't really use these terms much anymore. And the preferred term is to say someone has co-occurring disorders. According to the Substance Abuse and Mental Health Services Administration, or SAMHSA, about 20.5 million, or about 8% of individuals in the United States on average between the years of 2021 and 2023, as you can see from this slide, had a co-occurring mental illness and a substance use disorder. And while the numbers may seem small in comparison to the number of individuals living in the United States, we know that there are negative outcomes that individuals with co-occurring disorders experience. For example, studies have shown that individuals with co-occurring disorders have more severe symptoms of both the substance use disorder and the psychiatric disorder. Sometimes this happens because they may be less likely to take their medications because of one issue or the other, either they're using or their symptoms are very severe. They're also more likely to have poor physical health and to be hospitalized for psychiatric substance use or medical conditions, meaning there's higher service utilization rates among these individuals. The prognosis or the long-term outlook for individuals with co-occurring disorders, unfortunately, is worse than for individuals who either just have one or the other type of disorder. And lastly, on the social side, individuals with co-occurring disorders often struggle with relationship difficulties, have difficulty finding employment, and staying stably housed. So with that introduction, in this next section, we're going to review some of the major psychiatric disorders that are commonly seen in treatment settings. How this will work is that for each, there will be a brief case presentation, a review of the symptoms that person is experiencing, and what moves things from like someone having symptoms to maybe having sort of a syndrome or an episode, and then what moves from there into someone having an actual mental health or psychiatric disorder. So the first case we're going to talk about is Sean. So Sean is a 35-year-old male who works as an administrative assistant. He's been feeling sad, down, and hopeless every day for the past 2 months. He stopped participating in his local theater group not too long ago because he really wasn't enjoying it any longer. And he was having trouble learning his lines because he had difficulty concentrating. He's had no appetite for the past 3 weeks and has lost 4 pounds. He only sleeps for about 3 hours each night, and he just always kind of feels tired. He has passing thoughts of ending his life, but really no intention of acting on them. He's missed work at least 8 times in the past 2 months because of his symptoms, and he may lose his job because of poor work performance and absenteeism. So Sean, from this, is definitely showing signs of depression. So I have a table here for you, and we're going to do these tables for all the case presentations. So on the left-hand side are the symptoms of depression for this one, and these come from the Diagnostic and Statistical Manual of Mental Disorders, the 5th edition text revision, or the DSM-5 TR. And then what you see on the right are what Sean's symptoms are. So you can see the symptoms are depressed mood, feeling sad and empty. Sean has that. Markedly decreased interest or pleasure in activities, appetite changes, sleep changes, and both of those can either be an increase or a decrease, fatigue or loss of energy, difficulty concentrating or indecisiveness, recurrent thoughts of death, suicidal ideation or suicide attempt, physical slowing or agitation, and feelings of worthlessness or excessive guilt. So again, that brief story we just reviewed about Sean, he definitely has a number of these symptoms. He actually has 7 out of the 9. And so we would be concerned about him having at least symptoms of depression and perhaps an episode of depression. So what is he actually, though, experiencing an episode of major depression? So here's where we move from kind of having symptoms to really worrying if there's like a more serious condition going on. So a diagnosis of major depression requires 5 out of the 9 symptoms that we just saw on that table. And as I just said, Sean has 7, so he's kind of already there. In addition to having 5 symptoms, the person must be experiencing depressed mood or loss of interest in pleasure, loss of interest or loss of pleasure in their activities. If you don't have one of these, then it's not an episode of major depression. Sean definitely had both of these, and he also had the symptoms every day for 2 months. So when we think about whether or not something is a disorder, duration of symptoms, the amount of time someone's experiencing something is very important. So for major depression, symptoms have to occur nearly all day, nearly every day, and have to occur for at least 2 consecutive weeks. I just mentioned he's had his symptoms for 2 months, so he meets all these criteria as well. And then lastly, it's for a diagnosis of major depression, the symptoms have to be severe enough to cause significant distress or negatively impact social and or occupational functioning. So Sean also has these as well, because as we mentioned, he was not going to work, he may get fired. So there's definitely some significant impact on his functioning. So from the information we have so far, we'd probably be a bit concerned that Sean is suffering from major depression at this time. So now we're going to move on. We're going to talk about Irina. So Irina is a 27-year-old female who's been out of work for 3 months. She's excessively cheerful and on top of the world every day for the past 10 days. She's got incredible amounts of energy. She spends her time, she's writing a novel. She's been painting her entire apartment, and she decided to fix up an old motorcycle that she kind of randomly purchased online. She also invests $5,000 of her savings in an Antarctica housing development that was posted on social media. Sounds a little sketchy, but who knows? But she's putting her money there. She only needs to sleep 2 to 3 hours per night, and some nights she doesn't sleep at all. Her friends have started avoiding her because all she does is talk about herself. She'll say things like, "I've written the best horror book ever. I'm more famous than Stephen King." And she tells her friends she just can't stop talking. She quickly also becomes angry when they interrupt her or try to change the subject. So because she's not getting along with them so well, she starts going out alone and picks up strangers at bars and engages in unprotected sex with them. If you were thinking that Irina has symptoms of mania, you would actually be correct. So we're going to have another one of our tables. So on the left-hand side are the DSM symptoms of mania, and on the right-hand side are Irena's symptoms. So mania means abnormally euphoric, expansive, or irritable mood, abnormally increased activity or energy, inflated self-esteem or exaggerated importance, a decreased need for sleep. And I always like to make this point when I'm teaching people about bipolar disorder and mania. It's not that you're just sleeping less, you actually don't need to sleep. So we saw in our example with Sean, he wasn't sleeping very much, but he was tired. He wasn't feeling too good about it. When people are manic or hypomanic, they don't need to sleep. It's a slightly different thing. So I wanted to sort of stress that point for a sec. So people are also more talkative than usual, or they have this pressure to keep talking. They have abrupt shifts in topics or racing thoughts, an increase in purposeful activities or physical agitation. So they're kind of restless, can't sit still. They have excessive, reckless involvement in activities with negative consequences, and they're easily distracted. So you can see from all the X's that I put on the side that Irena has a number of these symptoms, lots of energy, writing a book, fixing a motorcycle, sort of getting engaged in things that probably aren't so good for her, investing money in sort of a dodgy sounding housing development, having unprotected sex, talking a lot, thoughts going really fast. So a lot of activity going on and really only sleeping very few hours. And really not needing that sleep to get by. So she has 8 out of the 9 symptoms that would define mania. So is Irena having a manic episode or a hypomanic episode? You might have heard those different types of terms. So there's a lot of overlap between the two. So for both mania and hypomania, you must have an elevated or irritable mood and an increase in activity or energy. You've got to have both. So this, unlike depression, this isn't an either or. So you have to have both of those two. And if you do, there's already significant concern that you're having a manic or a hypomanic episode. You have to have 3 or more of the other 7 symptoms, 4 or more if the mood is predominantly irritable. I'm not actually sure why they did that, but for some reason, if you're mostly irritable, you got to have more symptoms. You have to have symptoms nearly all day, nearly every day, which is common. We heard this with depression. We're going to keep hearing this again with the different disorders. The symptoms must be severe enough to cause significant distress or negatively impact social and or occupational functioning. So the challenge, and I mentioned before about time. So time is very important in terms of determining disorders or syndromes. So manic episodes last longer. So you've had a manic episode if your symptoms last at least 1 week, and a hypomanic episode lasts at least 4 consecutive days. So when we were talking about Irena, she had symptoms for 10 days. So at this point, we would be concerned that she's experiencing mania. So if someone has had a manic episode or a hypomanic episode, they may actually then be diagnosed with bipolar disorder, a bipolar disorder. So there are 2 types of bipolar disorders, bipolar 1 and bipolar 2. Bipolar 1, you must have at least 1 manic episode. Interestingly, with bipolar 1, major depression or hypomanic episodes could also occur, but they're actually not required for the diagnosis. So if you just have 1 episode ever, that means you meet criteria for bipolar 1 disorder. You may never have another one. You may never be depressed, never have hypomania, but that 1 manic period will have you meet criteria for bipolar 1 disorder. Bipolar 2 disorder is more focused on those hypomanic episodes. So again, those ones that occur for 4 days, 4 consecutive days. But for this diagnosis, you also have to have 1 episode of major depression. I know it can get a little confusing, but these are the way they are parsed out. So when we talk about people with bipolar disorder, we try to break it down into 1 or 2. So for Irena, she actually is having a manic episode. Again, it was 10 days. She meets a number of those symptoms. So we could say Irena does have bipolar 1 disorder from the information that we've been given. Next person we're going to talk about is Kevin. He's a 20-year-old male who is a college sophomore. When he's in his dorm room, he hears other students laughing at him and calling him a loser through the vents. And he also believes his professors were recently replaced by aliens trying to take over the world. He stops attending classes, he stops communicating with his family and friends, doesn't really feel like talking to them anymore, starts staying in bed all day with his headphones on, listening to music and just staring at the ceiling and doing very little else. So after a couple of months, his parents visit his dorm room to check on him because the dean of students called them because he's actually failing school. So when the parents see him, makes minimal eye contact with them. He really has little or no response to questions. When he does respond, his voice is very flat. He speaks in a monotone, and he's really unconcerned that he is failing all his classes that semester when he really had been a good student prior to that. So the concern for Kevin is that he's experiencing psychosis. So psychosis is kind of complicated. I know there's a lot more on this slide. I'll try to kind of not spend too much time on it, but do it justice. So symptoms of psychosis. So one is delusions, which is fixed beliefs despite conflicting evidence. Hallucinations, which are perceptions without an external cause. Disorganized thinking, which is loosely related ideas, indirect or incomplete answers, or incoherence when you speak. Abnormal motor behavior, so little or no verbal responses, no movement, strange or rigid postures, or repeated movements. And negative symptoms, which are the diminished emotional response, decreased activity, or limit emotions, or no interest in social interactions. So for Kevin, we saw he's thinking his professors are aliens. He's hearing voices through the vents. He's lying in bed all day. He doesn't really speak much. When his parents come to see him, he's very emotionally sort of restricted. So the one thing that was kind of missing in his story was disorganized thinking, but you can see he had a number of symptoms that are concerning for a psychotic episode or psychosis. So when does it become schizophrenia? So this is where things even get more complicated. So for schizophrenia, you have to have 2 or more symptoms, and at least one of the 2 symptoms must be the ones in bold. So either delusions or hallucinations or disorganized speech. So again, you can have the other 2, but you must have one of the other ones. You must have 2 or more symptoms, and at least one must be the one in bold. Sorry about that. Got a little confused. So again, delusions, hallucinations, or disorganized speech. You have to have the symptoms continuously for 6 months. So if you have these symptoms for a couple of days and then they go away for 2 months and they come back, it's a little less suspicious that you might have a disorder, consistent with schizophrenia. You really have to have the symptoms pretty consistently for 6 months. And within those 6 months, at least 2 symptoms have to be there pretty much all the time for 1 month, at least 1 month. And often it is there longer. And, just to go back to the idea of about 6 months. So this Learning Thursday is being recorded in September. So 6 months from now is March. So you have to really have all these serious symptoms pretty continuously, for 6 months. So from today until sometime in March is a pretty long time. So there has to be really evidence of these for a good period of time before you can say that someone has schizophrenia. The last factor that goes into diagnosing schizophrenia is what we've seen with other disorders. So again, sort of change in functioning. So it's a functioning level in schizophrenia in 1 or more areas is really significantly below pre-symptom onset. So things like work, interpersonal relationships, and self-care. And with Kevin, work for him was school. So he was failing his classes. He wasn't going to his classes. He wasn't interested in really interacting with his family or friends, so the interpersonal relations were down. And if he's lying in bed all day listening to music, he's probably not taking too good care of himself, but we don't have as much information about that. Last thing I want to mention about schizophrenia is that there are associated features. These are not required, so these are not DSM criteria, but something I like to mention when we talk about it, because these can also be serious things for people to live with when they have schizophrenia, but again, not diagnostic criteria. And that would be cognitive problems. So memory, attention are not very good. Sometimes people don't use the language properly. They'll use words sort of oddly or in the wrong context. And sometimes people, when they have schizophrenia, they don't seem to process information as quickly. They seem a little slower to take things in, even if it's something sort of really simple. Another associated feature, and again, not required for the diagnosis, is sort of a lack of awareness that they have the disorder. Like, some people really don't understand that they have this serious disorder and very much believe in those delusions and the hallucinations, that we mentioned when we presented Kevin's case. So it's a very serious disorder. And you want to be careful about saying people have schizophrenia, because it's again very serious. There's a lot that goes along with it. And you want to be thoughtful when you're thinking about the symptoms and the disorder. Next up is Olivia. Olivia is a 40-year-old female book editor. She's riding home on the subway one day when it stalls in a tunnel. She suddenly and very quickly starts experiencing extreme fear, a pounding heart, chest discomfort, difficulty breathing, tingling in her fingers and lips, shaking, sweating, and afraid that she's going to die. The symptoms get really bad after about 3 minutes, but within about 10 minutes, the symptoms have completely resolved. So this story, Olivia's story, may sound familiar to many of us, because a lot of people at some point in their life have had a panic attack, and that's exactly what this is. So the symptoms of panic attack are a rapid surge of intense fear or discomfort, palpitations, pounding heart or rapid heart rate, chest pain or discomfort, a sensation of shortness of breath or smothering, feelings of choking, trembling or shaking, feeling dizzy, lightheaded, and unsteady. And you can see Olivia had 5 of these from the check marks on the other side. But actually, there are more. Wait, there's more symptoms. There are 7 more, and those include nausea or stomach discomfort, sweating, feeling chills or a heat sensation, numbness or tingling sensations, feeling unreal or detached from oneself, fear of losing control or going crazy, or fear of dying. And from these 7, Olivia had 3 of those as well. So she had about 8 symptoms altogether. So to the other factors that go in with having a panic attack, again, it has to come on very rapidly. Like, it can't, it usually moves very, very fast. So you have to have that rapid surge of intense fear or discomfort, and you have to have 4 of the other 13 symptoms. Again, Irina had 8, so she would definitely symptom-wise be there meeting the criteria for a panic attack. The symptoms reach a peak within minutes. For Olivia, it was 3 minutes, and it can occur from a calm or an anxious state. So when does someone have panic disorder? So panic disorder happens when people have recurrent, unexpected panic attacks. So having one panic attack, so when someone had one manic episode, they had bipolar disorder. But it's not the case with panic disorder. You have to have recurrent, unexpected attacks. And at least one attack is followed by 1 month or more of one or both of the following. So an ongoing concern or worry about having another panic attack, and behavioral changes to avoid future attacks. So that usually means people avoid places where the attacks occurred or could occur. So for Irina, she may decide she's going to take taxis to work. Excuse me, not Irina, my apologies. For Olivia, she may decide she's going to take a taxi to work or a ride share rather than take the subway, so she doesn't have to be in a situation where she might have another panic attack. And as always, the symptoms must be severe enough to negatively affect social and or occupational functioning. So let's say Olivia started being late to work regularly, or she started cutting back on going out with friends because she was afraid of having panic attacks, then we would be concerned that she meets criteria for panic disorder. The last person we're going to talk about is Joseph. So Joseph is a 38-year-old veteran who served 3 tours in Iraq. During his tour, he drove behind another truck and drove over and detonated an IED. His best friend and 6 other soldiers were killed in the incident. He was originally intended to drive the impacted truck, but at the last minute, they assigned him to the truck behind it. And since the incident, he has lived with nightmares and vivid memories of the event, severe insomnia, flashbacks where he feels like it's happening again, panic attack symptoms when driving his car or he's on the bus, avoidance of news stories about Iraq or military movies or movies with car explosions. He also experiences a lot of guilt because he lived and his friends did not. And he has frequent anger. He lashes out at family and friends over really small issues that most of us would not be upset by. So this meets criteria for what we call symptoms of post-traumatic stress. So apologies, these tables got a little complicated, but there's a lot of things that go into post-traumatic stress and ultimately post-traumatic stress disorder. So I'll go through them, but again, apologies that they're a little busy. So symptoms of post-traumatic stress means you have exposure to actual threatened death, serious injury, or sexual violence. You can witness it, you can directly experience, so you are physically harmed, you can witness it, you can learn about violent, accidental trauma happening to a close family or friend. Or you can have indirect exposure in the course of job responsibilities. So if you are a police officer who frequently goes to the scenes of car accidents and you see people who are injured or killed, that would be there. So for Joseph, he witnessed the truck blow up right in front of him. So he definitely has the trauma that is needed for post-traumatic stress. Another symptom is intrusion symptoms related to the event. So nightmares, so dreaming about it, intrusive memories. So when you're trying not to think about it, but the memories just pop up, even though you don't want to think about it. Flashbacks where you feel like you're actually back in the moment. Sometimes it's just very brief, but Joseph may feel like he's back in the truck that's behind the one that's exploding. Emotional distress and physical responses when exposed to reminders. So Joseph was having panic attacks when he watched those types of movies or heard stories about Iraq. Persistent avoidance, which people stay away from distressing memories, thoughts, and feelings about the event, and avoid external reminders that bring up memories, thoughts, and feelings. So Joseph had all of these. There are also more symptoms. So there are negative changes in thinking and mood. So you forget important aspects of the event itself, negative beliefs about self and others, self-blame. So remember, Joseph had a lot of guilt, decreased interest in activities, negative emotional states or being grumpy or cranky a lot of the time, persistent inability to feel positive emotions and sort of this detachment from others. And then lastly, change in awareness and reactivity. So people have that irritability that Joseph had. Some may engage in reckless behavior, heightened awareness to the point where people will startle, give a very big startle to maybe to a noise that might not bother a lot of other people, difficulty concentrating, and Joseph, as we talked about, had sleep disturbance. So that's post-traumatic stress. So it becomes a disorder when the symptoms begin soon after the traumatic event. The symptoms occur for more than 1 month. And then you have to have, it gets a little complicated here, a few of these, a few of those, but those intrusion symptoms, you have to have one or more. Avoidance symptoms, you have to have one or both. Negative change in thoughts or mood, 2 or more, and change in awareness or activity, 2 or more. So I don't want to kind of go through everything again, but Joseph definitely had this, so we would be concerned that he had post-traumatic stress disorder. Okay, so those were all our case presentations. So I hope at this point that your understanding of psychiatric symptoms and what makes, what are symptoms, what might be an episode of something, and what makes a disorder has increased. But unfortunately, I'm going to make things a little more complicated again here in this discussion, because most psychiatric disorders that we just went through have one more criteria that I didn't really mention to you up until now, and that is the symptoms are not caused by substances, medications, or a medical condition. So as a psychiatrist, when I'm thinking about whether or not someone has one of the disorders we reviewed, I always have to consider this. And this is something that we need to think about, because if substances are involved, then it kind of changes the picture. So now I'm going to go back to our cases and I'm going to give you a little bit more information about each of them. So Sean, who we were worried about had depression, has been drinking daily for the past 3 months. Irina, who's been all elevated and writing books and doing reckless behavior, has been using cocaine and crystal meth for the past 2 weeks. Kevin, our college student, has been smoking cannabis almost every day for the past 6 months. And Olivia stopped heavy alcohol and Xanax use the day before she got on the subway. So now we're going to go back to our tables and I can show you how, so we still have our symptoms of depression, the individual symptoms, and then how there's the substance that they're using or stopped using is involved. So alcohol use can definitely cause depressed mood. It can change your appetite up or down, usually down. Sleep changes. People do not sleep well when they're drinking regularly. People feel tired from the effects of alcohol and can have difficulty concentrating or sort of, symptoms, sort of feeling kind of indecisive about all of that. So here we have 5 symptoms of depression that really may be related to alcohol use. So, it kind of confuses the picture a little bit. Is this really depression or is this related to substance use? Same thing with Irina. So she had a number of symptoms of mania, and actually stimulant use, so her cocaine and crystal meth use can cause all the symptoms of mania, every single one of them. So again, what's the picture here? Is it because she's using, or is it because she independently has bipolar disorder, is having a manic episode? For Kevin, symptoms of psychosis, cannabis use can definitely cause delusional thinking, those fixed beliefs without conflicting evidence, and people also can experience hallucinations. The other symptoms, not so much, but those 2 are definitely standouts. And again, we talked about when people have schizophrenia, they need to have those 2 of those 3, and there are those 2 right there that could be due to cannabis use. In terms of Olivia, so this is a little bit different. So her symptoms may be more related to alcohol and benzodiazepine. So Xanax is a benzodiazepine. So withdrawal from those substances. I put slower in this table because I do find that people just don't have the sudden onset of alcohol or benzo withdrawal, that panic. It doesn't usually come on really fast. It often builds, but it's not out of the realm of possibility that it could come on quicker. But all these other things, racing heart, chest pain or discomfort, trembling or shaking. We know people get very shaky when they stop drinking alcohol or using benzodiazepines if they've been using them for a long time. People get nausea, people experience sweating, they get chills and heat sensations. So there's a number of symptoms there that can be from alcohol or benzo withdrawal that also look like someone may be having a panic attack. So the question is, are these individuals experiencing the effects of experiencing a primary psychiatric disorder, or are they experiencing what we also have in the DSM, which is called substance-induced mental disorders? So substance-induced mental disorders, the definition means you have clinically significant disorder symptoms, so symptoms of depression, mania, psychosis. And you must have both of these. So the disorder symptoms start soon after substance intoxication or withdrawal, and the substance can cause the disorder symptoms. So we saw in those tables that, substances can cause a lot of psychiatric symptoms that then can add up and look like a psychiatric disorder. The symptoms are not better explained by having the disorder themselves. So sometimes you may have, the symptoms either started before the onset of substance use or intoxication or withdrawal is one way you can kind of think about it, or the symptoms continued well after intoxication or withdrawal ended. So if you see those very clearly, you would wonder that the person has a primary disorder. So one example, so let's go back to Irina. So if she had a manic episode at 17 and she had never touched a substance, never used them, and then she had that manic episode that now we're wondering, is it due to substances? Because she had that one episode in the absence of substances, the clear absence of substances, we would be more concerned that maybe she has a primary bipolar disorder. Or if she stopped using, let's say we didn't have that, if she stopped using, but those symptoms kept going on and on and on for months and months, and she didn't get any treatment, we would be more concerned that the bipolar was primary, because when the substances aren't around, she's still having these symptoms. And as always, the symptoms have to be severe enough to negatively affect social and/or occupational functioning. So I'm going to show you another table. So in this table, talking about substance-induced mental disorders. So on the on the left-hand side, you have the substances, alcohol, sedatives, cannabis, opioids, and stimulants. And then on the top, you have the different categories of disorders. So depressive disorders, bipolar disorders, psychotic disorders, anxiety disorders, and trauma and related disorders. So you can see, so there's a little legend on the bottom that certain substances tend to cause the disorders more when individuals are using or intoxicated. You can see straight across for cannabis. We see that for psychotic disorders and anxiety disorders. For stimulants, we also see that with psychotic disorders, so with the red X, usually when people are using. And then sometimes symptoms may only occur in withdrawal, which is designated by the black X, which means sedatives and opioids. You can see those anxiety disorders. But the real challenge is that you can see in both situations for most substances. So intoxication and withdrawal, alcohol can cause depressive symptoms, bipolar symptoms, psychotic symptoms, anxiety disorder symptoms, and so on. So a lot of substances, again, can during use and during withdrawal can present a picture that looks like any of those disorders. So you may have been thinking a few minutes ago when I was revisiting those cases, what happened to our veteran who had the PTSD type symptoms? So the challenge with that is that trauma-related disorders need to have a trauma. So that's the hallmark symptom. So while people who use substances are more likely to experience trauma, substance use in and of itself is not traumatic. Now, traumatic things may happen, again, while you're using and so forth, but it's not a trauma. So there is no such thing as substance-induced trauma-related disorders like PTSD. So I put that up there for completeness sake, because we did include that case, but wanted to make the point that really substances don't cause those disorders, but again, can lead to people experiencing trauma. So here's a table, here's a little diagram, again, might be helpful to kind of think about how psychiatric symptoms in relationship to substance use. So if someone is using substances and they stop using or their withdrawal ends, over time, you're going to see either the symptoms resolve or mostly resolve, which we have on the left-hand side. And you would probably be convinced that this is more substance-induced symptoms or a substance-induced disorder. But if those symptoms continue with little or no improvement after use and the withdrawal ends, we would, again, be concerned that they have a primary disorder or a disorder that was there before they got involved with using kind of any substances whatsoever. So other information that can help determine if a disorder is substance-induced or a primary mental disorder is the history of psychiatric symptoms over a lifetime. So like, when did they start? So I used the example before, maybe Irina had a manic episode when she was 17 and she wasn't using at that time. So that's a very helpful piece of information about whether or not that might be a primary bipolar disorder or was it substance use. If someone, you want to look at the timeline, I always would ask people, like, what was going on when you weren't using? Did you have those symptoms? Do you have any experience like panic attacks or major depression when you weren't using? That can be incredibly helpful for teasing out, what may be substance related or not. How severe were the symptoms of the disorder? This isn't always the case, but usually when people have a disorder that's not substance related, so a primary mental health disorder diagnosis or a psychiatric diagnosis, the symptoms are sometimes more severe. So if they're a lot more amped up because there's something else driving it, that's more than the substance. Not 100% true, but it's something that you can ask about. How effective were any treatments that you got? So sometimes people do get treatment for these psychiatric symptoms. And usually medications are not quite as effective when people are actively using. Would not say they don't do anything. It's important that people take their medications when they're using. But it's usually, if people respond sort of really well to symptoms when they are on medication, their symptoms respond very well, when they're on medications, that might be something that makes me think that it's a mental disorder rather than a substance-induced one. Collateral information family, friends, sometimes the people around us are better at telling us about things that are happening to us than we can remember. So talking to them about when symptoms started, their relationship to substances can be very helpful. And family history of psychiatric illness can also be helpful. We do know there's a genetic piece to most psychiatric disorders. So if everybody in Irina's family, I'm going to keep going back to her, had bipolar disorder, you'd be a little more convinced that she probably has bipolar disorder independently rather than substance-induced bipolar disorder. So sometimes I get asked this question, so I put in the slide to review. So when do you seek a mental health evaluation? So for a lot of you who, are working with individuals, when do you know that maybe someone else needs to talk to them and figure out things that might be going on for them in terms of their mental health? I have suicidal or homicidal ideation highlighted. I think those are sort of a major psychiatric emergency. So if someone is expressing those issues to you, or you're doing a screening like the CSSRS, excuse me, the Columbia Suicide Severity Rating Scale, and you're very concerned about them, you want them to get an evaluation. It may even need to happen urgently, or if people are talking about a desire to harm other people. If someone says to you, yes, I've been diagnosed with schizophrenia and I've been treated in the past, but I'm not taking medication right now, that's a good time to get someone a mental health evaluation, because we talked early in this presentation about co-occurring disorders. So if someone gets that disorder treated, hopefully that will have a positive impact, not only on that disorder, but maybe on their substance use as well. If anybody's talking about psychiatric symptoms and they're very much interfering with their functioning, they really, can't get out of bed, they're at risk for losing their job, and they wanted to get you want it to get a better look, that's a good time for a mental health evaluation. And if you're uncertain if these symptoms are substance-induced or related to a psychiatric disorder. So this talk is for educational purposes only. I would encourage you not to try this at home. If you really should have someone see a trained mental health professional, so a psychiatrist, psychologist, who has good grounding in both substance use and psychiatric disorders, to try to kind of help tease these things out, because it can be very difficult to do so, but they can work on that with the patient and figure things out. And then lastly, if someone requests an evaluation, sometimes people are really struggling with symptoms, and kind of goes back to that idea of trying to figure out if this is a disorder. If they really get seen and they get, and someone can clearly diagnose them with something where there's help, either through therapy or medications, that would be a really great thing, and will help, again, both the disorder, if they have one, and their substance use. So as we wrap up, just want to remind everybody about their ability to access substance use disorder treatment. So finding treatment and confidential support. We have our QR code for the OASAS types of treatment webpage. There's a lot there that you can access, including impaired driving services, crisis services, outpatient services, residential services, opioid treatment programs, regional services, help with problem gambling, and an awful lot more. So also then on the right is a little poster, a snapshot of a poster for our Hope line. So 1-877-8-HOPE or 88-HOPE-NY, or you can text HOPE-NY and the number is there, and that can get you connected with treatment. In terms of sort of crisis prevention resources, there's always emergency medical assistance. So as we talked about, if you're concerned about someone being suicidal or homicidal or potentially harming someone, you can always call 911. A lot of times they may take people to what we call a CPEP, or a comprehensive psychiatric emergency room, where people can get a very thorough evaluation and determine maybe they need inpatient admission for a mental health issue or substance use issue, or you can just have people go to their nearest emergency room. So even if there isn't a CPEP, people in the emergency room know how to work with individuals who may be at mental health crisis. Hotlines, we just mentioned the OASAS Hope line, so won't review that again, but we'll remind people about the 988 Suicide and Crisis Lifeline, which has been around for about 2 years now, where you can call or text or chat 988 if you need immediate crisis support. And then lastly, OMH has resources about community mental health promotion and support, which provides support and access to mental health professionals in the area where you live, and those are all accessible. So at this point, I want to thank you for having me. Hope you learned something today, and I'm going to turn it back over to Dean.
I want to thank Dr. Hennessy for joining me today. I hope you all find it useful while assisting clients in need of services. Your feedback is important to us. It helps us to know if we're meeting your educational goals and expectations. Once you have viewed the presentation in its entirety and completed the quiz, if prompted, please follow directions to access the SurveyMonkey website and take a moment to complete the evaluation, including suggesting any future topics for Learning Thursdays. Once again, thank you for joining us and keep up the good work.